Welcome to Human Health Lab, where science meets movement, nutrition, and mindset. Your journey to better health starts here. Two patients, same diagnosis, type 2 diabetes. Amir takes medications only. Jonathan uses medication plus a medically referred supervised exercise plan. After 12 months, Jonathan's A1C, fitness, blood pressure, waist size, and daily energy beats Amir's by a wide margin. Today I'll show you how much difference exercise makes, the science behind it, and exactly how to train safely if you have type 2 diabetes. Type 2 diabetes is a chronic condition where the body becomes insulin resistant, meaning your cells don't respond well to insulin, and over time the pancreas may produce less insulin. The hallmark is hyperglycemia, chronically high blood glucose. Insulin resistance, reduced cellular response to insulin, mainly in muscle and liver. Hyperglycemia, fasting plasma glucose more than 126 mg per deciliter. To our OGTT more than 200 mg per deciliter. Or A1C more than 6.5%. Confirmed on repeat test. Type 2 diabetes is a dominant form of diabetes, over 90% of cases globally. About 589 million adults live with diabetes today, projected to reach 853 million by 2050. That's 1 in 8 adults. Why does exercise work so well? During exercise, muscle contracts and opens a second pathway, independent of insulin, to pull glucose into the cell. This is driven by AMPK signaling and GLUT4 translocation. Repeated training increases capillaries, mitochondria, and GLUT4 content, improving insulin sensitivity for 24 to 48 hours after each session. Here's what the literature says when you add a structured, supervised exercise to usual care. 0.7 to 0.9 percentage points lower versus usual care. Largest when more than 150 minutes per week with supervised programs. Plus 10 to 12% improvement with regular training. Aerobic training typically lowers SBP 5 to 6 mm per mercury and DBP 2 to 3 mm per mercury in type 2 diabetes. Supervised exercise is equal to circa 1 kg weight reduction and 2.5 cm waist reduction on average. Bigger changes if energy intake is managed. Concurrent aerobic plus resistance training improves HDL and reduces TG and TC vs controls. CGM studies shows better 24-hour mean glucose and improved CGM metrics. Timing afternoon often helps. Compared with medication alone, adding a proper exercise program typically drops A1C by 0.8%, improves fitness 12%, lowers blood pressure, trims waist, and smooths daily glucose swings. Before we prescribe training, screen for complications and meds that change glucose responses. Symptoms of CVD, very deconditioned adults, or multiple complications. Coordinate with the treating physician. ADA 2025 endorses regular physical activity for most adults with diabetes. Daily food checks, fitted footwear. Avoid high impact if ulcers or severe loss of protective sensation. Consider cycling, swimming, rowing until skin integrity is stable. Watch for orthostatic hypotension. Heat intolerance. Progress gradually. Consider stress testing if symptomatic. Avoid high-intensity head-down positions, heavy Valsalva, and contact sports that risk vitreous hemorrhage. Monitor BP and volume status. Avoid dehydration. Moderate intensity is usually safe with individualized progression. Increased hypoglycemia with activity. Consider carb intake and or pre-planned dose adjustments under clinician guidance. Rare euglycemic DKA risk with illness, fasting, very low carb diets, or extreme exertion. Educate on 6-day rules and hydration. Avoid only with EGFR less than 30 or acute severe illness, otherwise compatible with exercise. For anyone on insulin or sulfonylurea, check glucose pre-exercise and sometimes during and after. Pre-exercise target 90 to 250 mg per deciliter. Below 90, take 10 to 12 gram fast carbs. Above target with symptoms, delay and troubleshoot. During prolonged or intense sessions, recheck every 30 to 60 minutes. Have fast carbs handy. Carb guide if at risk of lows. Roughly half to 1 gram per kg per hour, depending on insulin on board, intensity and duration. Post-exercise, watch for delayed nocturnal hypoglycemia. Considered a small mixed snack. Adjust bolus or basal. Here's the exact program I want Jonathan on. This works for most adults with type 2 diabetes. Then we individualize. 150 to 300 minutes per week moderate, for example, brisk walking and cycling, or 75 to 150 minutes per week vigorous. Spread over more than 3 days, no more than 2 days off. NHIIT if cleared. 2 to 3 non-consecutive days per week, 8 to 10 exercises, 1 to 3 sets of 8 to 12 reps, progressing load to moderate, hard. Combined training lowers A1C the most. 2 to 3 times per week, yoga, static stretching, balance drills, especially in neuropathy and older age. Every 30 to 60 minutes, stand or do 1 to 3 minute light activity. Helps post-meal glucose excursions. Afternoon sessions often improve glycemia more than mornings. Helpful if safe or feasible. Session structure for Jonathan. Safe, repeatable, progressive. Warm up 5 to 10 minutes. Easy walk, cycle plus mobility. Main set, aerobic 20 to 40 minutes. RPE 5 to 7 out of 10. Or HIIT, for example, 6 bouts of 2 minutes hard, 2 minutes easy. Resistance 25 to 35 minutes. Squat, hinge, push, pull, core. Start at RPE 6 out of 10. Progress weekly. Cool down 5 to 10 minutes. Finish with 10 to 15 minutes easy walking if post-meal to blunt glucose spike. Food check, hydration, record CGM and glucose, RPE and symptoms. If you have type 2 diabetes, ask your doctor for a formal referral to an exercise physiologist. I've linked free tools below. You can print and take to clinic. Then save this video and follow prescription for 12 weeks. You'll feel the difference. If you're passionate about science-based tips on health, fitness and nutrition, hit that subscribe button and join the Human Health Lab family. New videos every week. Stay strong, stay healthy.